Now I invite Professor Rückert for the last lecture of the session. Thank you.
Thank you very much. What I would like to do in this talk is show you some examples of how AI might also help you with the actual image acquisition in order to acquire images faster, better, and perhaps more beautiful images. And I just wanted to start off by some disclosures, including that I'm a co-advisor of Heartflow and a co-founder of Ixico. Now, you will have seen this particular slide here already before. Marlene showed you this example, and it sort of illustrates where deep learning sits within the broader context of machine learning as well as artificial intelligence. And I'm going to show you mostly work from the deep learning scenario where we might actually use neural networks to help us with acquiring better images. So you will have seen similar slides before. The idea really is inspired by biology to take neural networks as we might have them in the brain and actually mathematically formulate these neural networks. And perhaps really the breakthrough which came in these neural networks has been published sort of at the sort of turn of the millennium by Jan LeCun with these convolutional neural networks you have heard about already. And it's quite striking to know that, as was already mentioned by the previous speakers, that these inventions really that led to the Turing Award to some of the founders of this area, including Jan LeCun. And for those of you who don't know what the Turing Award is in computer science, it's effectively the Nobel Prize of computer science. So in his work, Jan LeCun actually used this for digit recognition, and this was the first time that actually a computer could read handwritten digits to sort letters for the US Post Office, and really has produced a very significant breakthrough. Now, what he is, the neural networks you see, they have an architecture as shown on this slide where you have a number of layers where you extract features, and then you compress these features into another layer, and you make these layers deeper and deeper, but also narrower and narrower. And that forces the neural network to learn more and more high-level features based on which it actually can recognize whether the image contains a cat or a dog. Now, in our scenario, this is useful, but perhaps an even more useful neural network is a neural network which you see here, where after I have contracted all the information, I now also expand all the information. I'm expanding it basically to the same size of the input image, and that allows me to do what we call a dense classification. So I can do a classification that's very useful. So I'm going to use mostly these type of neural networks in the following, where probably the lowest value sometimes we think about is in the image acquisition, but actually that's already very much a computational task. So the image acquisition, none of you will ever look at case-based data. Typically, you always will use a computer to reconstruct an image. So that's already something we can do very well with a computer. If we go a bit higher in this pyramid, then a number of these tasks can make the diagnosis and prediction. And that's where probably a neural network is a bit difficult to use, because we really want to have a logical, a reasoned explanation of why we make a particular diagnosis. So let's have a look and start at the sort of the lowest layers, and that's what I'm going to spend most of my time on. If you are familiar with MRI imaging and how MRI images are acquired, you probably know that we acquire the image in a domain called the case-based domain. Then we apply a Fourier transform to the case-based domain. We can reconstruct the image. And due to this is relatively slow. So for patients that can be sometimes uncomfortable, for example, actually I'm going to skip most of the data. I'm only going to acquire a quarter of the data by randomly sample this case space. And that has an advantage that if I only acquire a quarter of the data, my image is going to be acquired 4 times faster. That's great. But if we can think about, can we actually recover? Is there enough information in this undersampled image to recover the full quality image and have all the advantages of accelerating the acquisition but still recover the full image? And if you view this in the framework which I showed you in the beginning, where I put an image in and where I now want to have another image as output, I can ask the neural network to learn how to remove these aliased artifacts from the image and produce a new image which looks much nicer and much cleaner. So you can do that. We have done this in previous work, but you have to be a bit careful how you do this, because you also want to generate an image which is representative of all the patient's anatomy and what you have actually measured. So what we do is we have created a neural network which operates both in the image domain and in the case-space domain. In the image domain, what we do is we have a number of layers which remove the aliasing artifacts from the image. And after we have done that, we go back to the case-space domain and we make sure that the data is still consistent with the measurements we have acquired. And then we can sort of iterate forwards and backwards between these two. Now, if you do that, you can actually do things which are shown on this particular slide here. I'm showing you here a undersampled cardiac MR image by a factor of 6 on the left-hand side. So you can already see that this image is probably not clinically useful. In the middle, you see the reconstruction using a neural network. On the right-hand side, you actually see how the ground truth, the fully sampled image, would look like. And you can see that this actually works reasonably well. And it works even for very aggressive undersampling rates, up to a factor of 11 or 12. And the reason why this still works is that we're looking at dynamic imaging. So there's a large amount of spatiotemporal redundancy. I'm imaging the same object over and over again, and only a small part of the image is actually changing. And that is really the reason why I can actually go so fast. Now, this is a nice example doing, if I wanted to look at cardiac function, I can use similar ideas to, for example, now enable us to do, for example, coronary imaging, coronary angiography with MRI. I'm showing you here some example of work by our colleagues at King's College Hospital in London, where they have developed a machine learning approach for reconstruction, which enables you to reconstruct, reformat in 3D the coronary volumes in the heart, and you can then compare them to how they would look like in a CT volume, and you can now image these coronaries within 5 minutes in patients. You can then, of course, also actually go through the entire image stack and sort of look at these volumes and compare them, for example, how they would look compared to a CT volume of the same patient. Now that really shows you that you can now get the scan times so low that actually you can do this type of imaging, which would not be possible if you don't have these acceleration techniques. But there are also other things which you might be able to do. Some of you might have heard of a technique called magnetic resonance fingerprinting, where the idea is that you actually use your MR scanner and you acquire thousands of images, all heavily undersampled. So these heavily undersampled images look very, very poor in terms of image quality. And they're generated by using randomly varying acquisition parameters. That sounds very strange, but there is a logic to this. If I randomly sample my acquisition space, I can then use a so-called dictionary approach to reconstruct all my images. So I'm fitting these dictionaries to my undersampled data, and I can now reconstruct any arbitrary tissue contrast from these undersampled acquisitions. So the benefit here is that I get a T1 map, a T2 map, and for example, these B0 maps from the same acquisition. So instead of running multiple sequences one after the other, I can now reconstruct any contrast from these acquired data sets. And I can decide retrospectively which contrast I would like to reconstruct. And I'm showing here some work which shows that you can even do this in moving objects such as a heart, where we can reconstruct now T directly from one single acquisition, which are clinically acquired from a stack of short-axis cardiac MR images. If you would typically reformat them, for example, in the long-axis direction, you will see that these data sets have quite thick slices, so very anisotropic resolution. And if we take a machine learning approach, a deep learning approach, we can take some training data, some high-resolution data. We can simulate low-resolution data from this high-resolution data, because actually corrupting our high-resolution data and turning it into low-resolution data is something which is actually quite easy. But then we can actually ask the neural network, can we also recover the inverse of this process? Can we learn from low-resolution data how the high-resolution data looks like? And again, we can use a neural network, pretty much the same neural network I showed you before, and we can now, for example, reconstruct high-resolution cardiac MR images from this low-resolution acquisition. And the nice thing about this now is you can reformat those volumes in any arbitrary plane to look at actually which is the best viewing direction for this type of volumes. Now, Marlene has already shown you examples that you can use these networks also for segmentation. And that's quite interesting. So we can, for example, train a network instead of removing artifacts from the image. We can force the network to label, for example, the image, which you see here, an example of the heart. You can, for example, label not only static images, but you can label entire time series of data. And this labeling is now very, very fast. We can label probably an entire stack of cardiac images in less than a second. These approaches are relatively reliable, even if we apply them for the entire cine sequence. The other thing which I think is very important to realize is that machine learning has enabled us to take the same neural network and apply it to many different domains. So if I now want to segment, for example, instead of a cardiac MR scan, a whole body MRI scan, well, I can use the same neural network, I just need new training data. So we now have a very versatile approach, because if we retrain our system with new training data, we can move to, for example, whole body MRI, or in this particular case, we, for example, can segment brain lesions in patients with traumatic brain injury, very reliable. So we can use the same methodology, and I think that's a very powerful approach. We no longer have to develop a custom-built solution for every single image data set. So at the end, I want to also show you how we might actually take this forward. And of course, in many cases, we are really interested in making, not only segmenting, for example, the heart in patients with pulmonary hypertension, but we're interested in making diagnosis or diagnostic decisions about the patient. And if I, for example, segment the heart in a stack of images, I might also use a neural network to not only look at actually the anatomy, but also to look, for example, at the motion trajectory of every point in the anatomy. And I can build these 3D motion maps of the heart, which might actually tell me more than just the structure of the heart. And if I do this with a neural network, then I can say, well, to my neural network, why don't you also learn features which are not only useful for segmentation or for motion information, but also for predicting, for example, survival. So what we have done here is we have taken this neural network which segments these images, but we force the neural network to also make a prediction about which patients are going to, how long they're going to survive if they have pulmonary hypertension. And if you do that, you can see that if you do a sort of conventional analysis, a survival analysis, you don't have really a very good separation between those patients which survive for longer and those which don't survive for longer. If we actually add all these features together from the neural network, we can now do a much better survival prediction of patients with pulmonary hypertension. Now I want to sort of conclude with sort of showing you a bit where I think AI really might change the game in radiology. So if you look at the traditional medical imaging pipeline, we acquire our data, we reconstruct our data, we then perform analysis of the data, and then finally we do interpretation of the data. But this is an entirely serial process, where one part of the processing doesn't talk to the other one. Once we have acquired our data, once we reconstruct the data, we can no longer go back and actually change our acquisition. And that's really suboptimal. Moreover, the entire pipeline is not really optimized for the clinical endpoint. You as a clinician will know what you want to measure, but we're not really optimizing the and reconstruction, but also between reconstruction and analysis, and therefore by acquisition and interpretation. Ultimately, we want you as a clinician to drive how we acquire the data, how we reconstruct the data, and how we analyze the data. So we want to have this end-to-end optimization, and we might actually be able to do this with neural networks. So one of the things I can do is I can take this entire pipeline. I showed you every single step of this pipeline I can effectively solve with a neural network. Why don't I simply go directly from the acquired data to the diagnosis with a neural network? And I think that raises a very interesting point. I think we asked earlier, focus on the clinically important, useful information. And I want to show you in the last example one single example that this might not be all pure speculation. So I've shown you many examples of where we, for example, try to segment the heart in cardiac MR scans. And we can now ask ourselves the question, do we actually need the images, or could we do this directly in case space? So could I, for example, take this case space information, which I'm showing you here as an image, and can I directly reconstruct the heart from it? And in this example, you see this, it's possible. The image which I'm showing you here at the bottom is only shown for verifying the result. But I'm recovering the segmentation directly from case space. I can do this even with only 10 lines of case space. And if I push very, very hard, I can also do it with 1 line of case space. But of course, you're now seeing that you're starting to make mistakes in this process. But I guess this shows you that actually there might be other ways of extracting clinically relevant information from this data. And with that, I want to just acknowledge all my colleagues who helped with doing this work, and thank you very much.
Thank you very much for all of you. I think this session was most interesting. We have learned that actually artificial intelligence has started 40, 50 years ago. We have learned, and you have shown that and indeed increase the quality of the images, but the question is, what are we going with all these images? So thank you very much. We have time for questions now, and I think the speakers will be very happy to take your questions. If you can raise your hands, please, and ask for the microphone. Who wants to start? Oh. No? Okay, so let me start. I would like to go back to your comment regarding the data quality. So you said, yes, indeed, in a perfect world, we would like to have a very high number of data and all of them high quality. But sometimes we can make compromise. Can you expand a little bit this issue and see which one and how do you deal with that? You can take the microphone.
So it's important that your data covers all the kinds of scenarios that you would like to apply your machine learning algorithm to in the end. And how much data or the quality of data that you need will be different for different applications. Typically for image segmentation, you may not need that much data, but you need to have seen all the kind of variability, most of the anatomical variations that are present in the population that you would like to apply it to. So then, if I'd have to make a trade-off between collecting more data or collecting higher quality data, I would probably go for higher quality data, but maybe fewer slices annotated or so. On the other hand, if you go to the radiomics-like applications, if you want to predict a diagnosis or a prognosis directly, still there will be some resistance to labeling, to noise in the labeling. But what becomes really important is to avoid bias in your training data, as the examples that I showed. And therefore it would be important to take into account what we usually don't do at the moment, to take into account confounders in our modeling as well.
Thank you very much. Let's see.
All the things you mentioned, they're very interesting. I came here worrying, what is the future for radiographers as partners to the radiologists, and is there any role? And thank you, Professor Bonmati, for outlining so many things. So it made me feel very happy that we could share the burden of the workload of AI. I'm interested to know, what are the skills we need to teach to the future workforce, radiologists, of course, and radiographers, so we can work together prepared for a future with AI. Thank you.
Yeah, maybe, well, I have at the end no idea of which is the right answer, but maybe we have to teach how to approach to a changing world. No? Things are changing quite fast. What we learn at the doing now, what are we trying to implement in the near future, and how should we be prepared for that change? No? So the culture of change, I think that's the most important aspect.
We will take the last question, please.
Emanuele Neri. I was inspired by your lecture when you showed the importance of artificial intelligence in the workflow, in the medical imaging workflow. The question probably is for everybody here on the podium. Do you think that the real impact of artificial